Hi, this will be the second part for the cardiology lecture. So we'll begin where we left off on the first one, and that was with heart valves. We talked about valves ensuring the one-way flow of blood and an oblique section here. You can see these heart valves in with a better aspect actually of their cusp. This would be an echocardiogram showing actually those valves and how they are functioning. So when we think about the valves and how blood fills these atria and then move into the ventricles, when it moves into the ventricles, as the ventricles fill with blood, the valves close. So that first sound is the AV valves closing. The second heart sound comes from the semilunar valves closing. So again, I think we had stopped on that part, so we will pick up with circulation. This slide here, I think, is worth bringing your attention to because it looks like a crazy kind of slide with all the numbers. But what this is actually illustrating, and I think it's a great thing to do, and there's actually a little exercise that a lot of students are asked to do, and I may be asking you all to do it too, is that you follow a red blood cell through the entire circulatory system. So for example, let's go ahead and use these numbers and start with where you are if you are a little red blood cell. You are in the right atrium. You have been to the system. You've been coming back from the system by way of the superior or inferior vena cava, but you're not, let's just say you're in the right atrium. So you don't have very much oxygen there, but you're loaded with CO2. You're going to pass the right AV valve, the tricuspid, and now you are in the right ventricle. So first right atrium, second tricuspid valve, you pass by, you're in the third right ventricle. Fourth here, you're passing by the pulmonary valve. You're in the pulmonary trunk, and then the pulmonary arteries split off because you may either go to the left or you may go to the right lung, but either way you're going to the lungs by way of the pulmonary arteries. In the lungs, you're going to pick up oxygen and drop off that CO2 you had, and you'll come back to the heart by way of the pulmonary veins. If you went down the left pulmonary artery side to the left lung, you'll come back by way of the left pulmonary veins into the left atrium. So here you're in the left atrium. You'll pass the mitral valve, also known as the bicuspid, also known as the left AV, and now you're in the left ventricle. From the left ventricle, when it contracts, you pass by the aortic valve, and now you're in the aorta, and then you will be sent to the system. From the system, you will drop off the oxygen, pick up CO2, and you will come back by way of the superior vena cava if you went to the upper extremities, or if you had gotten sent to the lower extremities, you would come back by way of the inferior vena cava, but now you're back in the right atrium. So I hope you see that it's a closed system. By being able to be a little red blood cell and know where you're going and what you pass by as far as valves, it really helps you to learn and intuitively understand this closed system that we call the cardiovascular system that includes two pumps, the right pump, that's the pulmonary pump that sends you to the lungs, and the left pump, that's the systemic pump that sends you back to the system, and then you do it all again. And as a red blood cell, you do that for 120 days. You're going around and around the system for about 120 days, or your life cycle as a little red blood cell. So spend some time with that, because I may give an assignment where you have to actually write down those structures. And it wouldn't matter where you started. If you started in the left ventricle, you would know that when the left ventricle contracts, you pass the aortic valve and go to the aorta, to the system, and then you would know it no matter what, because it's a closed circular system. Okay. I have already mentioned to you that it's the coronary arteries that nourish the heart. The heart is an organ that has to have blood supply itself. So all of those tissues that we talked about, especially the myocardium, the muscle of the heart that's contracting, has to have a constant blood supply. So you have left coronary arteries, right coronary arteries, and then they split off. And we got to see those on in the first part on some of those diagrams. If blood supply ever gets cut off to the heart, if the coronary arteries ever become occluded or blocked, then a myocardial infarction could happen, which is what people call a heart attack. An infarction is pathological death to a tissue because of lack of blood flow. The heart has a built-in mechanism to sort of protect, though, against slow blockages, because as we age, there tends to be a narrowing, or sometimes people have plaque formations as well. And you will hear about people having bypasses that have like a 90% blockage, and you think, you know, what was getting through. But if it's happening slowly, you do have the ability, this is called anastomosis, this is the ability to defend against that, but it's typically only if it happens slowly, and this will help the heart to get alternate pathways. Anastomosis is an alternate pathway to get blood to that tissue. So again, if the interruption is happening and it's kind of slow, then the heart can kind of deal with it. But if it happens suddenly, the heart can't deal with it. This is why oftentimes in emergency rooms, it isn't the older, much older patients who are dying from the myocardial infarctions. Many of them, once they do pass away, and if they have autopsies, for whatever reason they passed away, there'll be evidence that they'd had many small little heart attacks, but the heart had found a way to get blood supply to it. The people that will often have the major heart attacks and the ones that they can't compensate for are sometimes the younger people. So 40s and 50s and 60s, they will have the major heart attacks, and there's no way they can defend against this, and they don't have time to make an alternate pathway, so they have major heart attacks with much of the heart muscle wall being damaged. So there's also coronary veins that are going to return the blood once it's delivered oxygen and picked up CO2, return it back. Most of that goes just like the regular red blood cells would go to the right atrium. There's a little bit that goes straight because it's right there. It goes straight into the right ventricle, but most of it is in that pathway that we just studied. So, you know, the right atrium, passing the tricuspid to the right ventricle. All right, so coronary arteries and coronary veins that are feeding, nourishing the heart, and returning blood back to the pulmonary circuit. The cardiac muscle is a little bit different than skeletal muscle and smooth muscle in that it depends almost exclusively on aerobic respiration. So you really can't go without the oxygen there. It actually has some protein called myoglobin that is storing some extra oxygen, and it also has storage form of glucose in the form of glycogen. So myoglobin is a protein that can help to store a little bit of extra oxygen, and glycogen storing glucose, because you know glucose and oxygen were the reactants in aerobic respiration that can be used in the cells to give off CO2 and water, but in the meantime make lots of ATP. Large mitochondria and numerous mitochondria, which is larger and more numerous than any of the other muscles. And again, because it has to resist fatigue. You can't, skeletal muscle can get fatigued and to the point that it won't even function anymore. But you don't want that happening to your heart, and it really does resist fatigue because of that. We also have we know that the heart actually depends on extracellular calcium more than the skeletal muscle does to help in these pathways as well. So the heart is said to be autorhythmic, and that is really true. It means that it has its own built-in pacemakers. The pacemaker are these cells that make up a little area called the SA node, which stands for sinoatrial node. This slide actually in text form takes you through how this node fires and works, but I think this picture actually maybe is really worth 1,000 words, because this picture shows you too. Remember, the heart is not flat. It's not a flat picture. It's three-dimensional. So we understand that this right atrium and this left atrium are actually sharing a wall here. There's a node of cells called the sinoatrial node, the SA node, that acts as a pacemaker that is firing a signal. And when it fires, it sends that electrical current immediately to the left atrium, but also through the right atrium. And this is going to give the signal for the atria to contract. That signal is going to hit this AV node, and it's called that because it's between the atrium and the ventricles, It hits this AV node, and then that becomes electrified, and the signal gets sent down through these bundle branches to what are called Purkinje fibers that you can see are encircling the ventricles. So then the ventricles will get a signal to contract. But where it starts is here at the SA node. So this is how current, or a signal, an electrical signal, actually moves through the heart. First, the atria, then down through the ventricles to the ventricles, so that they actually contract. One complete rhythm, cardiac rhythm, is actually referred to as the sinus rhythm. Most adults at rest fall within 70 to 80 beats per minute. One rhythm, 70 of those or 80 of those. Now, there's really kind of a broader range than that to be considered normal at rest for adults. And it can be anywhere really from like 60 to 100. But most people fall within that 70 to 80. So beats per minute at rest. Children can have a normally higher heart rate than adults can have. There are a couple of terms you should know. Systole or systole. Systole or systole, you'll hear it, is contraction. That means contraction. Diastole means relaxation. So those are terms you should know, because we'll talk about them with blood pressure. And sometimes you'll hear those terms related to the heart contracting. Contracting, systole or systole. Relaxation, diastole. Arrhythmia means that there's an abnormal cardiac rhythm. And it can be for a lot of different reasons. It can be because of electrolyte imbalances. It can be because of heart block, like they give you the example here. Failure of this conduction system. There's a block somewhere in the system. So it can be for a lot of different reasons. But arrhythmia, the term itself, just means that the heart is out of rhythm. And when the heart is out of rhythm, it's always a risk that the heart will get a signal to stop. Just stop. And that is known as cardiac arrest. Cardiac arrest is actually different than myocardial infarction. Myocardial infarction was that the heart's being damaged and attacked. It really, you can see it on the when you're looking at the conduction of the heart. You can see that damage sometimes. But cardiac arrest means the heart stopped. And there are a lot of different things that can cause that. Now, this conduction system, and we just looked at the SA node firing to the atria, and also the AV node, which sent the signal down to the ventricles. We can measure that. We can measure it by doing something called an ECG. You often hear about it as an EKG, and that's the same thing. The K is just the German spelling of cardiogram. So EKG is the cardiogram with a K. They're the same thing. Now, most of you would recognize this kind of tape. If you saw it, you would recognize this, where it looks like, you would recognize this. As when you saw this, you've seen it on, even if you haven't seen it in real life with somebody you know in a hospital or whatever, you've seen it on TV, right? In dramas. So you kind of know that this is, they're measuring the heart beats. And each rhythm, each sinus rhythm, one beat, should have very rhythmic type types of presentations on an ECG. You can measure from spot to spot, and that would be the one rhythm. And then you can see how many of those there are in a minute. And if it's something like that, then you can actually get the beats per minute. You can also count them. But what I want you to know is what this basic normal ECG, what these little bleeps in the ECG, what they mean. The first one is called a P wave. And this first little wave that happens, here's the P wave, P wave, P wave, P wave, P wave. This P wave is when the SA node fires. The SA node fired. And the atria get the signal, and you can see the atria are going to contract. When the atria contract, that signal also got sent to the AV node. So that AV node is getting the signal. You see this QRS complex, which means the ventricles are now getting the signal, and the ventricles contract. The T wave is when the ventricles are going through resolution and they're beginning to relax. It will be a period of time between each heart rhythm. That is the refractory period, which is, you can think of it as like a rest, because it's built in that no heart signal will be sent during this time. It's really like a built-in rest period, right? And then the next rhythm starts. SA node firing, atria contracting, AV node getting the signal, ventricles starting to contract, and then repolarization, it's called, or relaxation of that ventricle, and then another refractory period. So this is what's happening during one cycle. This slide is the slide that really shows it. So the P wave, SA node firing, atria contracting. QRS, AV node firing, ventricles contracting. T wave, the ventricles repolarizing, and refractory period starting. So that's the typical, pattern. And when you look at one, if it seems incredibly rhythmic and you see everything P, QRS, T, and that looks perfect, right? Then if you realize that this looks perfect, then this next one is obviously something's wrong here. And what you notice is wrong is that there's no P wave, which means it really doesn't necessarily mean the SA node's not firing. It's just that it's not enough that the atria are getting their signals. And so instead of having a nice contraction, it's more of a jelly-like reaction and the movement. And this is referred to as Afib, atrial fibrillation. Someone's in Afib. People who are in Afib can sometimes take medication that can keep them out of Afib. But if they are in Afib, it means the heart is not contracting quite like it should, and they're going to be at heightened risk for strokes and, heart issues. So this would be an important thing to diagnose, and it would be an important thing to treat if possible. Now, another thing that you can sometimes see are premature ventricular contractions, PVCs, they're said to be. It's thought that we all have occasional PVCs that happen where we have a premature ventricular contraction. Some people say they feel it. They feel like their heart flutters, or that something turned over or something. They'll say that they feel, but you shouldn't have too many, and you shouldn't be feeling them often. And actually, it needs to be examined by a cardiologist if that's the case. So this is what it would look like on an ECG. That's what that would look like on an ECG. If you saw a patient's ECG tape, and you saw this, and then this picked back up again, what this would typically mean, because you all know on the P wave, the SA node had fired to the AV node, but it looks like the AV node is being blocked. This is serious because it's the ventricles that eject blood out of the heart. So if the ventricles are not getting that signal, then yeah, this is an issue. And this tape would indicate, this bottom tape would indicate that no pumping is happening at all. So the person is in cardiac arrest at this time, and without immediate intervention to restore a rhythm, then this is it for them. So these, we understand that ECGs are really incredibly valuable. So, you know, these were the basics of an ECG, but there are more than 100 different patterns that someone who specializes in this could look at the pattern and say whether this person, electrolytes are low, or this person really is having a heart attack, or this person might have X, Y, and Z. So like I said, there are about 100 different diagnoses that you can do from an ECG. A lot of times now when someone has an ECG, it's all electronic, so the computer will give a diagnosis too, but that is not a definitive diagnosis. It takes a specialist to actually look at those and see and to get an accurate diagnosis. But they can tell a lot of things from an ECG. They're very, very valuable in cardiology. The cardiac cycle, we said, is going to be SA node firing, atria contracting, the ventricles end up relaxing during that time to take the blood, then the atria relax and the ventricles contract, and then that quiet refractory period. That's one cycle. So one cycle, I have already talked about the heart sounds in the first part, so you all know what the heart sounds actually mean. And this next part, what I'd like to talk about, is called ejection fraction. So when the ventricles contract, the right one's sending blood to the lungs, the left one's sending it to the whole system. How much blood is ejected at that from those ventricles? How much blood is being held in the ventricles and ejected is called the ejection fraction. So that is actually can be measured using several different tests, but including echocardiograms. So when we think about that, we can use that. It's referred to as a stroke volume. We can actually use that along with the beats per minute to actually evaluate what is called the cardiac output. So cardiac output is something that's a valuable measurement, because if you know someone's, for their size, their cardiac output is adequate, using stroke volume, how much is being ejected for each beat and how many beats per minute, if you know it's adequate, then they are considered to be in good cardiac health. But if the cardiac output is low, then you can expect those patients to walk the stairs, or to maybe even use the restroom go to the walk to their bathroom from their bed. That may be putting too much of a burden on their heart. So it's an important, in cardiology, it's an important evaluation is when someone has the cardiac output evaluated. So there's all kinds of measurements you can see here, looking at the ECG, looking at the heart sounds, looking at what is happening with the valves. This is kind of nice because it puts those major events together for you in a little graph. Typically, for adults, typically 70 to 80 beats per minute at rest. But normal could be 60 to 100. If you're below 60 beats per minute, there's a term called bradycardia, and it's somewhere in the notes, maybe in a little bit, meaning the heart rate's low. If it's over 100 beats per minute in someone at rest, then it's called tachycardia. And again, if those two things are observed, then they need to figure out why. And you would also want to figure out if there are any medications that could be causing that. And you certainly wouldn't want to give a medication that could exacerbate either one or the other of those situations. So cardiac, the rate of cardiac cycle is going to be important, the beats per minute. Now, what happens though in these ventricles? We know the right side is sending to the lungs in a closed vascular system by way of pulmonary arteries, picking up oxygen, dropping off CO2, coming back by way of pulmonary veins to the left side. The left side then sending to the system, right? But What happens when the ventricular output from the right is not balanced with the left? Because it's a closed vascular system. Then something's going to have to give, right? Correct? So when you think about this, if the right is output exceeds the left, if there's more blood being sent to the lungs than the left can accommodate, then the blood kind of backs up in these vessels, giving water more time to leak out, and this can lead to pulmonary edema. So this can happen when the left side is compromised and it's not able, the right is putting out more than the left because the left's not functioning the way that it should. So it accumulates in the pulmonary tissues. And what would happen if the left is putting out more than the right can do, so the left exceeds the right, then it's going to back up, fluid is going to back up in the system. So in the systemic tissues it can back up. And this is not a good thing either. When the ventricles are not in balance for how much they're putting out, and there is a backup, well, let's go into that. When there is a backup, this is, if it's serious enough, this is referred to as congestive heart failure. So you've probably heard of CHD or CHF. CHF, congestive heart failure, CHD, congestive heart disease. This sounds awful when people who aren't in medicine hear this. They're thinking their loved one is about to expire on them. But actually with treatment, this can be maintained. You know, it can be managed oftentimes, not always, but oftentimes it can be managed for a long period of time. And not that it is going to be resolved, but a person can live for quite a long time as long as they are being treated appropriately and it's being managed. So congestive heart failure is when the ventricles are not in balance. So obviously, two pumps that we want to be working synchronously, important to be working synchronously. So cardiac output I've just mentioned to you. We're going to use stroke volume along with the heart rate, so beats per minute, and stroke volume, and that's going to give us what cardiac output should be. Now, what you want to have happening is that you can evaluate when someone's active versus when they're at rest. And what you would like to see is that there is a difference between maximum and resting, meaning that the person can accommodate, like when they're walking around or when they're doing steps or when they're exercising, their cardiac output goes up and they can accommodate that. But someone who doesn't have any cardiac reserve, meaning there is no difference, then it means that you have to limit and have them understand that they have to be very careful because they don't have the cardiac output that they need to maybe be doing certain things. So can we maintain our cardiac output as being a really big difference, the reserve being difference between exercise and rest? Yeah, we can do that by living well, I guess you'd say, exercising, moving, eating right, maintaining weight, sleeping, all of those things would help with cardiac reserve and make sure that there's a big difference between the two. Again, we talked about adults and, saying that children have higher beats per minute, and that makes sense because children have a smaller stroke volume, so it's got to beat more often. The heart has to beat more often. That really makes sense. These are the two terms that I needed you to know. So tachycardia, if someone has a higher heart rate at rest, a lot of things can influence it: stress, anxiety, medications, legal or drugs, illegal, either one, heart disease, and even body temperature can influence this. So bradycardia is going to be, a low heart rate, and again, this can be sometimes explained. Athletes with very healthy hearts, they don't have to beat as often. They don't. And their stroke volume is really good too, so they don't have to beat as often. They have an increased stroke volume, and their cardiac output is great. There are a couple of terms here that I want you to get off of this slide. I'm not sure why this is in the title, but anyway, the two terms are chronotropic and ionotropic. The term chronotropic means that this is something that is going to affect your heart rate. So a positive chronotropic med is going to increase heart rate, or a positive chronotropic hormone would increase your heart rate, and a negative one would decrease it. A positive ionotropic medicine could actually increase the contraction, not the rate, but how hard it contracts. And a negative ionotropic would actually decrease the contraction strength. So these are a couple of terms, and the reason I want you to know them is that sometimes when you're looking at meds and what their effects are, because you don't have to know that for your patients, you'll see that you might see that you have a patient who's bradycardic, who has bradycardia. They already have a pretty darn low heart rate. Actually, you've kind of flagged it because you're watching it, and it's 50, might be high 40s, it's low. And you look and you notice that they've been given a drug that actually has a negative chronotropic effect, which means it's going to decrease it even more. You need to stop that med. That is not indicated, that medicine. And it might have been indicated for them prior to whatever they're in there seeing you for now, but it's not needed now, and so you need to stop. You need to stop that. Okay, so that's why I want you to know these terms, because you'll see those sometimes on the PDR, the desk references for medications, when you're looking up what medications do. So 2 terms. What else do I want you to know about this? Let's see, I don't know. Just the idea that when we think about the nervous system having an effect, the sympathetic nervous system is our fight or flight. So you all know with from the endocrine system, when we talked about the sympathetic system, epinephrine and norepinephrine, they're going to increase all of your vital signs. They're going to increase the heart rate. They're going to increase the contraction strength. So they have positive chronotropic and positive ionotropic effects. So the sympathetic nervous system has that. The parasympathetic system is our housekeeping maintenance system, and that's going to have usually negative chronotropic effects. So we're going to, and ionotropic. So they're going to have absolutely the opposite of the sympathetic system. So good. We have built-in mechanisms in our arteries, like the baroreceptors that are measuring stretch. So if someone's arteries are being stretched because their blood pressure or whatever is going up, signals get sent to try to get that to drop back down. So we have baroreceptors, we have proprioceptors as well. All of these are built into our autonomic nervous system, so you don't have to think about this happening. This just happens. We know that other things can affect it. We can have emotional stimuli that will absolutely sort of hijack your normal centers. So we understand that is the case. Chemoreceptors that are built in, these are all built in, that are measuring your pH, your CO2, your oxygen, and so we understand that. This little slide gives you some chronotropic chemicals, and I told you about the hormones, norepinephrine, epinephrine. They're going to stimulate, aren't they? Fight or flight. Caffeine stimulates, nicotine stimulates. We know all of those things that can do that. Potassium has the greatest chronotropic effects, and most of you already know that potassium being out of balance can be the most dangerous electrolyte to be out of balance. If it's too much potassium, then it's going to be less excitable, or too little is also going to be a problem. So either way, too low or too high can lead to heart arrhythmias and can lead to cardiac arrest. So potassium needs to be just balanced and maintained. So I think these last couple of slides were just FYI kind of slides, but obviously exercise and cardiac helps with cardiac output. So, you know, go figure, we should all be exercising, and we understand that this can help to keep a healthy heart. It does it more than just the way that it helps the stroke volume. It also helps it because when you're exercising, it's helping that pulmonary circuit. It's helping blood flow back to the right side, the right pump of the heart. Another thing in here, and we'll finish this one up today, is this chapter is coronary arthrosclerosis. You'll also hear arteriosclerosis, a different spelling, but pretty much what this is saying is if you had a artery, like a long artery, and you made a transverse cut across and then looked at it, this would be a normal looking picture because you're seeing most of its muscle. Artery is really a thick vessel, and the middle layer is muscle. It's lined with endothelial on the inside and the outside, and the lumen is the opening of the vessel where blood is flowing through. So in life, before this dissection was made, this was filled with blood. With each heartbeat, blood was rushing through, and this was filled with blood, and blood was putting pressure on the inside of these walls, and blood was moving. Somebody who has arthrosclerosis, what ends up happening is plaque forms on this inner endothelial layer. This middle layer is muscle, but the endothelial layer that's lining the lumen, plaque can form and tear it away from the muscle, and then plaque can actually push it out. And as plaque is forming, you can see how much it is blocking the lumen. So instead of having a lumen that's this size, like this one, you now have a lumen that is like only about 10% of this lumen. And so whenever you've heard that someone had a bypass because they had 60% blockage or 70% blockage or even up to 90%, this is what the vessel, the inside of that vessel was looking like. Very little blood was being able to move through that site. So again, coronary arthrosclerosis, that's what that is pertaining to. And those coronary arteries are the ones that they are going in and evaluating and looking at to see if there are any blockages to blood getting to those tissues. Patients who've undergone bypass surgeries, whether it's a double, triple, quadruple bypass, whatever, most of them, as soon as they wake up, if the surgeon got to do what they needed to do, the cardiologist got to do what they needed to do in placing a stent or ballooning or whatever they needed to do, most patients, as soon as they wake up and take some breaths and are alert, will say they already feel better. The pump is already working well enough that they feel a difference. So, that's kind of a beautiful thing. Well, that's the end of our cardiology chapter. We have about 30 minutes or so of notes on the vessels. That will be the next one on our vascular system. So that will be the next one. But I'll sign off for now, and there will be a quiz on what we just covered in this lecture. So good luck, and I'll see you on the next lecture.